Okay, excellent. Welcome to today's meeting of the Health and Social Care Select Committee at London Borough of Hillingdon. Happy New Year to everybody. I had a debate about when you can stop saying Happy New Year, and somebody did say the 1st of February, so I'm going to go with that's a Happy New Year. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners and adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinets, and quite often we also submit our findings to our external NHS partners who we're reviewing if we're reviewing them. My name is Councillor Nick Denys and I'm the chair of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure your mobile phones are on silent. We're not expecting a fire drill, so if the fire alarm does go off, please follow Nikki out of the building. Please keep your microphone muted when you aren't speaking, then unmute to speak, and as chair I will call on those to speak in the meeting. It's worth noting that some of the councillors in this committee will be using devices to access their agendas and papers. So we're now going to move on to the agenda. Nikki, are there any apologies for absence?
Chair, we've had apologies from Councillor Hagger, and Councillor Davies is here as her substitute.
Welcome, Councillor Davies, thank you for joining us. Are there any declarations of interest? No? We're all good? Fantastic. Minutes of the meeting of the 3rd of December. Are we happy with those minutes? Yeah? Happy? Excellent. Thank you very much, Nikki, for doing those. An item for everything we're talking about today is in public, is that correct? Fantastic. Okay, right. So, we can move on to our first main item, which is the public health update, public health in Hillingdon update. And I'd like to welcome Sharon Stoltz, is that correct? Yep. For me anyway, our new Director of Public Health here. So I've just got a big open broad starter question, then other committee members probably have other questions. But as you've just recently started here, can you tell us really what are your ambitions for Hillingdon when it comes to public health?
Okay, thank you, Chair. I suppose my overall ambition is to improve the health of the people living in Hillingdon. When you look at the health of the population in Hillingdon, we actually compare favourably with the averages for London and for England. But when you look at some of the health data within Hillingdon, we can see variation across the borough, with pockets of where we have far worse outcomes, where we can see that people are perhaps having shorter lives, where we're seeing more people experiencing the causes of early mortality, such as cardiovascular disease, cancers, respiratory disease, for example. So one of my ambitions is to level the playing field, if you like, or narrow the gap across Hillingdon, so that we're tackling that variation in health outcomes. That can take some time. There is a graph in the report that was published with the papers that shows that some public health outcomes lend themselves to improvements in the short term. Other issues, such as obesity, for example, can take a generation to have an impact. And so part of my ambition will be to develop a public health strategy for Hillingdon that actually encompasses those short, medium and long-term areas that we need to be particularly concerned about. I suppose one of those short-term priorities is to review the services that we're currently commissioning. So all local authorities receive a public health grant from central government that is used to commission services for local people, such as health visiting and school nursing services, stop smoking services, services to support people who may have drugs and alcohol misuse, for example. we have a range of commission services. So one of the short-term areas I want to focus on is reviewing those services, looking at the quality, looking at the outcomes that patients are experiencing from those services, and whether they are actually delivering what we want them to deliver for local people. So that will certainly be one of my short-term areas to focus on. Some of the other areas then are really making sure that we focus on giving all of our children the best start in life. There is a whole range now of research evidence to show that if we can ensure that we get the right support, the right interventions in for what's called the 1,001 days from the moment of conception to age 2, that if we can give children a healthy start, then that actually sets them up throughout life. And when you look at the appendix to the report, you will see that there are a range of public health outcomes where perhaps Hillingdon could be doing better. If we look at early stages of development at age 5, language development, for example, is one of the areas of focus. The way that we tackle that is by working with families from birth in improving their communication with their child. So that is one area. But then thinking also as we go through the life stages, thinking about how we can support people of working age to be more healthy. And then as we start to get into the older ages, what we can do to help people remain independent in their own homes, and how we can support people to be physically active, to tackle issues like social isolation. So as Director of Public Health, I'm concerned about the whole population from conception all the way up to older age, and how I then target the areas of focus is to really use national published data, such as in the Public Health Outcomes Framework, but also using local intelligence and information as well about what the particular health needs are and focusing on those. So all of that will be brought together in a public health strategy, which I hope to bring to the committee once that's actually ready, which will probably take me around 6 months to develop. I think I'll need to develop a rich understanding of Hillingdon and consult with partners and with residents as well to help me to develop that. Thank you.
Thank you. We'll be very interested in that once it's developed, and also probably at the same time the reviewing of services and how you feel like we can improve how we offer public health services. My sort of final question is based on at the end of the report there's a bullet point which says one of your priorities for 2026 is development of proposals for an integrated healthy lifestyle offer. I mean, that sounds like quite a big ambition. I've got no problems with big ambitions at all, but I mean, what do you mean by that? What can the council do with that to try and get good outcomes?
So what I mean by that is, and this will be a medium-term priority rather than a short-term priority, is at the moment we have separate services for stop smoking, for supporting adults who may wish to lose weight, for example. That isn't necessarily how people manage their own health and their own health behaviours. So if you go to see your GP currently, you are overweight or obese and are advised to lose weight. You may smoke as well. It involves a referral to separate services and accessing different services. That isn't necessarily the best way for that individual to be supported. It leads to fragmentation. It's not good from a customer perspective, then a service user perspective. Particularly, people have busy lives. You don't want to have to go to different places to access services. But it isn't necessarily the best value for money either. And so lots of local authority areas now are moving towards what's called an integrated lifestyle service, where you may either self-present or a hospital consultant or a GP might refer you to go to one service where you can actually sit down with someone who can talk to you about your health, your health behaviours, your what you're eating, how active you might be, whether you smoke, whether you're perhaps drinking a little too much alcohol, and then going to one service where you can have that integrated assessment and be supported for all of those issues in one service is preferable, really, to having to have referrals to lots of different places. So this is an area of development I'd like to focus on, but this is a particular area that requires consultation with residents and with the people currently using these services to find out what would work best for Hillingdon residents. I've commissioned these services in other places that I've worked, but what will work for one area may not necessarily work for another. So it will be taking the time to find out what will work best for the people of Hillingdon, really.
And again, that is the type of thing that we're very interested in, obviously, when you come back in 6 months or so time with the strategy, and that underlying sort of thinking and evidence behind the strategy for different areas, because Hillingdon is one borough but obviously not one place completely. So thank you. Any other questions? Yep, Councillor Martin.
Thank you, Chair. Hi, I just have a question. There's some really promising results when compared to some of the neighbouring boroughs, but if I can put it crudely, the London Borough of Hillingdon is 15.4% unfitter and fatter than some of our neighbouring boroughs. So I was looking at some of the data, and I was asking some colleagues I was working with today about the health checks that NHS provides for the 45 to 74-year-olds who don't have any other issues. And not one of those men I was talking to had any idea of what that check was or have been invited to it. So is that a proactive service that the GP should reach out to anyone over 45 asking for a friend? Or do we have to realise that this service is offered to come forward? So maybe that would help statistically bring us in line with some of our other neighbours. Thank you.
Okay, so I need to explain a little bit about what the NHS Health Check Programme is, and then I can answer your question if that's okay. So the NHS Health Check Programme is a national screening programme. And as you say, it is to offer all adults between the ages of 45 and their 75th birthday with no existing health problems to a health check with their GP. So it's a 5-year rolling programme, so people get invited once every 5 years. So it's an invitation program rather than self-selecting program. So the idea of it is that, yes, everyone between the age of 45 to 74 should be offered in every 5-year cycle one invitation to go and have that NHS health check. I know, because I've been looking at some of the data for this, that Currently our performance in Hillingdon doesn't reach that threshold at all. Hillingdon isn't unique in that. If you looked at the data across the country, no one is achieving 100% uptake. They may be receiving 100% invitation, but not everybody who is invited will turn up for the checks. So no one is achieving 100% uptake. And we have recently changed the way that we commission this programme. So the contract used to be with individual GP practices. The contract is now with the GP Confederation. That means that rather than individual practices having the administrative burden of having to do the invitations and everything, they're working more collaboratively through the Hillingdon Confederation. We're hoping that that will improve the number of people that are being invited, and also will improve uptake as well. That has only recently started, so I can't put my hand on heart right now and say that that is actually going to make a difference. But we'll obviously be monitoring that. It links to another programme of work which is focused on hypertension. So know your numbers. So there is a campaign that's going to be launched locally soon, next month actually, a public-facing campaign to encourage people to have their blood pressure checked. Part of that will also be giving people a little bit more information about what the NHS Health Check is. The name doesn't help. You know, if you know nothing about public health, or you're not connected with anyone, if you had a text or a letter from your GP inviting you for an NHS health check, I'm not sure that people would necessarily understand what that was, and if they felt healthy, would they turn up for it? So there is another piece of work I think we need to do around marketing it, raising awareness of the importance of going. So part of it is the performance of the contract, but I think there is certainly more awareness raising and marketing of the programme that we need to do as well.
And are you in a position to share our borough's invitation rates versus the uptake, and if possible to split that between male and females which go to that? Because it's just interesting to know whether it's more of a male kind of, we hear a lot that men just ignore their own health and miss these checks. Are you in a position to share that?
We can certainly separate out invited from the number of people who take up. I'm not sure whether right now we can say whether there's difference between men and women, but that is certainly something I can take away and look at, so that if the committee at some point in the future would like to look at that, a performance report perhaps in a little bit more detail, then I can certainly take that away and look at that.
Yeah, that would be really useful, thank you. Councillor Bells.
Thank you, Chair. Welcome, thank you for your report, and welcome to Hillingdon. Just looking at your appendix, there's lots of, obviously, lines on it, and obviously we tend to look at the red ones, the glaring red ones. I know there's lots where things are good and whatever, but the red ones, and stuff screaming out is the vaccination rates in the borough are really low. Have you? I mean, I know you can see it for yourself, and you're aware of areas where the vaccination rate is really low or really high. Is there any way of looking down a breakdown of areas where in the borough where the uptake is bad, and also is it in relation to the GP coverage? Because at some areas like Heathrow Villages, there's no GP, very little GP coverage, and it might transcend. This is why we're getting red figures so much.
Okay, so Vaccination is a really interesting area. So the NHS is responsible for commissioning and providing vaccination programmes. But as a local authority, one of our statutory duties that's normally discharged through the Health and Wellbeing Board is to have oversight of the health of our population. So as a local authority, we're in the interesting situation of being responsible for an outcome that we have no control over, because it's the NHS that commissions and provides vaccination programmes.
Which part of the NHS? Because obviously the NHS is a massive thing.
It's the Integrated Care Board is responsible. Well, NHS England, but it's being absorbed into Department of Health, so it's discharged through NHS England and Integrated Care Boards. But you're right in that it is GP practices, by and large, who provide the vaccination programmes. Maternity services are responsible for providing some vaccinations to pregnant women. GPs aren't responsible for providing the school-based vaccination programme to children aged 5 to 16. But they are responsible for the early childhood vaccinations and flu, etc. Why I say it's an interesting area is because there are many things that impact on vaccination coverage. You're absolutely right that one of those areas is access. So can people get to their GP? Pharmacists offer flu vaccinations, for example. So if people can't get to their GP, can they get to a pharmacist? Are the vaccinations delivered at a time that is convenient for them? So all of those things will have an impact. But in this country, vaccination is a choice. We don't have compulsory vaccination in this country. Some countries, such as France, for example, require children to be vaccinated before they start school. We have never taken up that approach in this country, and there are no indications that we would. So people will take up a vaccination if they choose to. And it's certainly true that particularly since the COVID pandemic, social media has had a huge impact on whether people will choose to take up an invitation for a vaccination. So we are fighting quite a big battle here in trying to get good, evidence-based, reliable information to parents of his children or adults about the facts of vaccination, to kind of tackle some of the myths that are on social media. But at the end of the day, it is people's choice. So our responsibility, my responsibility, working with the partners in the system, is to make it easy to be able to access a vaccination if you want one. So certainly there are discussions going on as part of winter planning around how we can make access to flu vaccinations easier, for example, but also how we think about the way that we communicate, the information that we put out to people, so that people are making an informed choice about whether they have a vaccination or not. So there is no simple or easy solution. We need to tackle it in a number of different ways. But it is a concern because the reason vaccinations are there is to prevent vaccine-preventable diseases. And we know, not in Hillingdon, but some other parts of the country, we've had some deaths in children from measles, for example, because they weren't vaccinated against measles. We have admissions into hospital every winter and demands on adult social care if people haven't taken up a flu vaccination or a COVID vaccination, for example. So falling vaccination levels is a worry because, as well as the impact on individuals, it has a wider impact on the system, impacts on the hospital and social care. So I wasn't here in Hillingdon when we were doing all of the winter planning for this year, but we usually start thinking about winter planning in the spring, so it will certainly be something that we'll be starting to think about kind of March, April time, planning the winter vaccination programme for next year.
Councillor Punja.
Thank you, Chair. Welcome, and really glad that you're here to level the playing field, as you say. Raising awareness is always something that I think we hear many practitioners come in here and talk about, and I think that's a big thing around health per se, per communities. Two things that I wanted to ask about was you've got a table on your report on page 12, which is from the Robert Wood Foundation 2014. I just wondered, 12 years on from that report, whether that box of how things are broken down into percentages would change, and whether there would be one done for Hillingdon as a borough that would show us that kind of a graphic in whether it's education, air quality, built environment, whatever it is, because I think that's quite important in terms of looking at the landscape of the borough. My second question into that as well is that the graph underneath, or the graph scale underneath, which part of that scale is your strategy looking at, or is it looking at all of those parts? Because there's quite a lot of work, so I just want you to know what the span of your strategy would look at.
Okay, so the public health strategy, bearing in mind I've only been here a short while, so I'm still thinking about the best way of developing this, will or can, based on your question, look at over a 10-year. So a strategy can be 3 years, it can be 5 years, it can be 10 years. If we were looking at a 10-year public health strategy, for example, it would be possible within that to identify what the short, medium and long-term priorities would be over that 10-year period. And that could be underpinned by a local outcomes framework that would actually set out the indicators that we're going to use to be able to measure progress over that kind of 1 year, 3 years, 5 years, 10 years, etc. So this is a national framework. Not all of the indicators are necessarily directly relevant to a local authority public health strategy, but it would be possible to be able to develop such an approach based on what we understand to be the key issues for the people living in Hillingdon. So you wouldn't try and look at everything, because if you look at everything, you'll achieve nothing. So it's about really focusing in on the things that are particularly relevant. And some of those areas we've already touched on. So we know that we have too many children carrying excess weight, so that would be one area that we would want to focus on. We know that when we look at the causes of people losing years of life, so people dying sooner than they should do, when we look at the causes of that, it is cardiovascular disease, it is diabetes, it is heart disease, it's stroke. It is about people developing cancers. Not all cancers are preventable. Some are linked to lifestyle issues such as smoking, alcohol misuse, etc. So there are things that we can do focused around prevention. But we can also focus on improving access to screening. So one of the areas in the appendix shows that we're not doing particularly well in Hillingdon currently around people responding to invitations for cancer screening, for example. So the strategy would be really focused on those things that the evidence tells us are amenable to change. So focusing on those things that we know we can do something about, but also focusing on those things that we that we can see are problems locally that we need to be focusing on. One of the challenges, I think, is that public health alone can't tackle a lot of these areas. So we know that the house that you live in, the environment that you live in, the level of income that you have, your social connections, your education, all of those things impact on public health outcomes. So any public health strategy would also be focusing on how the public health team needs to be working in partnership with other teams across the council, and how we're using our public health grant and our commissioning powers as a council to be able to improve some of those wider determinants outcomes as well.
I remember a long, long time ago that in this committee we kicked around the idea of making a sort of public health aspect part of decision making in general. But anyway, I think certainly when your strategy is done and you come back and talk to us about it, I think we'll probably need a full meeting actually just to go through it all and talk about what it means and priorities and also levers to change sort of behaviour as well. So does anybody else have any other questions yet? Councillor Davis.
Thank you and welcome. So I just wanted to make a point about the vaccinations. So my child, we were really keen on the vaccinations, but I found that when we went to our early years appointments, when you do the 10-month review, they go around the room and they ask, has your child been vaccinated? Have you vaccinated? A lot of people said no. A heck of a lot of people did say no. But the NHS staff didn't actually drive the reasons behind it in the room. It was just, oh, okay, you've not got your child vaccinated. And I did have some reservations myself, especially with the MMR. When you have a look online, it's not available separately. So I can see why there is some concern about it. With the table, it does seem exceptionally high for vaccinations, that we're really underperforming. Is that table including the hotels? Because my thinking is that there's a number of people coming through. Is that what's pushing us so far behind? That we've got, I don't know, how long do you have to be in the borough before that data is captured? Because I see it was 2023 to 2024. So there would have been an element where the hotels have come into play there. Is that data captured with the Hillingdon data?
So the vaccination data is based on GP registration. So if you're registered with a GP in Hillingdon, you would be captured in this data. One of the areas that I want to look at is how, as a public health team, we can access some of this information in more real time. So because it's NHS data, GP practice data, I don't have access to that. But it is possible to have access to that data through negotiation. Mm-hmm. Because by the time we have data like this, this is 23-24, we're already in 2026. Yeah. So there isn't anything that we can do now to influence this outcomes data. And we also need to have a better idea of whether any interventions that we put in now are working.
Mm-hmm.
And we can't wait 2 years to know whether what we're doing now is working. So one of the areas that I want to look at is how we are working collaboratively with GP practices and with the NHS to have easier and earlier access to some of this information. You're absolutely right about the attitude of healthcare professionals, and there is research that shows that if a healthcare professional is ambivalent about vaccination themselves, then they're less likely to be able to help someone to make an informed choice about vaccination, because perhaps unconsciously they pass on their views. Whereas with the proper training, and I think the proper support, we should be able to encourage our frontline healthcare professionals to be more confident in having conversations about vaccination. It is still ultimately that parent's choice, or that individual's choice, but it's about the way that information is shared, the way that conversation goes, that I think can have an impact. So that will be some of the areas that we'll be wanting to look at to improve some of these figures, so that hopefully when we're looking at this in 2 years' time, we won't be red.
Yeah.
One of the issues, I think, with refugees and asylum seekers is when they arrive in this country, they don't bring their vaccination data with them.
Of course.
So we start from scratch. So we assume that they're not vaccinated, and they're offered the vaccination program that we offer in this country, and then obviously they need to catch up. So that may have some impact on this, but not a sufficiently large impact for it to be read like this. So there'd be some, but not a huge impact. This is general Hillingdon population and low levels of vaccination uptake across the whole population. If we were going to look at it in pockets, then we might see variation across GP practice data if we were looking at GP practices that had a high number of registered patients that were asylum seekers or refugees, for example. So you may notice it in small area statistics, but you wouldn't expect it to have an impact across the whole population.
Fine. I have one more question, if I may, Chairman. The report notes that the overall health in Hillingdon is good, but there is a significant variation between communities. Have we got data of how that's broken down by the community, the wards, etc.? Because I would expect there to be a difference potentially with my ward in Charville, whereas maybe the ward in Northwood Hills would be slightly different. So I'd be interested if, I'm not on this committee, but maybe it'd be nice to have that shared award breakdown. I know I'm only visiting, but in future it might help.
We do have that data, yes.
Yeah, thank you.
So, yes, it is something that if the committee wanted to look at that, we could pull a report together. Or maybe a presentation. It lends itself more to a presentation than a report, I think. But, yes, we do have that information.
In a form where, obviously, it can be shared with ward councillors who would be on this committee, as Councillor Davis has said, who might find it interesting. On the vaccination point, in March, we have one of our health updates where we have the ICB and the GP Confederation, among others, coming. We can put as a pre-question to them, actually, about the vaccinations, because I think they'll have a very important, contribution to that. Just as a sort of, so we can do some further investigation into that point. Okay, well, thank you very much, Sharon. That was really interesting, and I really do look forward to the strategy when it's sort of, in a place where you can come and talk to us about it and show it to us, and we can talk behind it and what it will achieve. So, thank you very much for coming to see us. You don't have to stay for the rest of the meeting. You are very welcome to if you wish, but you don't have to. Right, excellent. So we're going to move on to the next item, which is the budget. Let's have a look. There's a few budget things. So yeah, the budget setting report. So we have Sandra Taylor, Corporate Director of Adult Services and Health. We have Steve Muldoon, who's our Corporate Director of Finance, and Martin Story, Head of Strategy Finance, Adult Social Care. I should have brought my glasses to this meeting. Just before you sort of start presenting this budget, something that's very important to me, and I think Steve will recognise this from audit, where I sit on, and we've had contact on audit, and Sandra through conversations that we've had. And I'm trying not to use the R word, because I don't want to start a debate about the R word, but in previous years, the budget that was set might not be as accurate as it could be. How can you give me confidence that this budget that's been set has been tested and put together an appropriate level, that it is the best possible estimation that we can have of what is needed over the next year, certainly in the next few years, in terms of adult social care in Hillingdon?
Thank you, Chair. Yes, I think it's right and proper that we start the meeting by explaining how we've worked, and Steve will take over with the real detail about our budget setting and how we're taking that forward, because it's from a practice point of view and an operational point of view, that has been me, and that's me working that up. But with Martin, with a transformation finance lead, we've looked at the growth that is required in adult social care to set the budget. So what you'll see in this budget, and Steve will explain it in more clearer detail than I can, but what you'll see in this budget is that over the next year, the growth includes some catching up, as we're calling it, in terms of the deficit and rebasing and resetting the budget to make it right. But we've spent, I wouldn't say weeks, I'd say months and months working through what the growth model is, and it's really important that in adult social care we understand that, because it's not a scientific straightforward, because somebody can come to us with needs that were not thought about previously in terms of our numbers. So we can have people rock up and need care and support, and rightly so. So we've had to build a model that we have looked backwards and forwards on, and we've worked really hard to work out what the demand rate is. We've used the Poppy and Pansy data. We've worked incredibly clearly to understand what the driver of cost in adult social care has been, and it isn't always people. So I think we talked about it, and Martin certainly talked about it with Matt at the last committee. We know that cost of care has exponentially risen. So we've got two things that are driving our growth. It is the numbers of people and the demand coming to our front door, and we've got the cost of care that's going up and up. So before I hand over to Steve, just to talk through a little bit about that, we've talked to the committee over the last year about the things that we're doing to control that. And the model that we've created has been a very detailed model which looks at every primary support reason, and that means everybody's needs are captured in here. So we may have a lowering number, we looked at in the graph last month, lowering number of older people, 65 plus, requiring care home placements, but we've got a higher number of people with learning disabilities and mental health needs. So the growth isn't everyone's perception of it's older people being discharged from hospital. It's much, much more complex than that. And you'll be aware from Children's Committee and other committees the high growth in young people with special educational needs, and how those young people, some of those very complex young people, will come through into adult services. So we've based our growth on what we believe to be the next 5 years of growth in terms of what we expect to see, focusing on the first 3 years and how, and obviously review, and how we expect to see the costs managed with the projects that we've talked to the committee about, which is around our own care home services, bringing things in-house if needed, doing things differently, reviewing modern practice, and really understanding the market and managing our market very closely. So all of those pieces of work have contributed to the model and how we will see that growth grow and hopefully stabilise with the introduction of the nursing beds at the boroughs, which will move through into the next financial year, so 26-27, and further work to develop further care services in-house. So everything has been backed up by that work, digging deep into the demand on care services that we have, how we can provide those differently. And I guess the final part that I would want to add to that is that all of that is considered in the least restrictive, most positive, proactive care model that we need to take forward. So I'm going to hand over to Steve and let Steve talk about the modelling and the growth, and then we can take some questions if that's okay.
Thank you. I guess the starting point for delivering a more realistic budget has been, first of all, to understand where we are in the present day. So that started with looking through the savings that we're achieving this year and having a realistic view on deliverability of those, challenging those hard, as well as understanding what the demand position and the growth is in the current year and comparing that with how we previously modelled it. So it feels like we've been playing a little bit of catch-up each year, and this was a year for me to set that straight as far as possible, to recognise that there are costs that are not budgeted for, that are ongoing in the base and should be put into the base budget, so that we have built that into that you will see in the papers as rebasing. You'll also see there's a couple of line items in there which relates to substantial saving items in the current year that we are writing down in the budget, so putting budget back in to the base to cover that expenditure for next year. So it starts with getting in the right position today. In terms of modelling, we have been looking back over recent years to understand at a kind of a subcategory level, so home care, for example, or learning disability or older people, and so on, in terms of the different rates of growth. So they all have their own different rates of growth. You can't just apply one figure for the whole budget for adult social care. So we've done that analysis, looks back to understand the change in the number of clients that we support, and how that's changing, and therefore to drive a weighted average and a more realistic position of what we think therefore the growth into the coming years should be. Similarly on the inflation side of things, so modelling that over time and seeing where we think that will be going into next year, irrespective of CPI inflation. So there's been a lot of work to understand where we are today, as well as kind of get a much more realistic grip on where we think the trends have been and are likely to go. So that's kind of getting that clear position. We've also then taken the savings proposals through a series of challenge sessions, both officer-led but also with cabinet members and with corporate directors in the room looking at those. We did the same with the demand pressures, and to understand how that's all looking, and asking lots of questions to really probe and understand how they're formed and whether the assumptions are realistic. And then, obviously, as I said, we've gone through the savings to write down savings going forward, as well as kind of testing those savings, looking ahead. That said, we will continue to keep the pressure up, as it were, in terms of making sure that what is being put forward, that there is grip on and momentum on delivering those. So in a number of cases where those proposals are deemed to be more complex, more involved, harder to deliver, I have asked people to produce delivery plans, so more detailed delivery plans behind those, rather than just providing a very summary saving proposal which gets talked about and everybody agrees that's the right thing to do and that seems reasonable. Is that actually where a lot of this could fall down is in the implementation and delivery, making sure that things are started early enough so that you get a full year effect, or as much of the saving into the year as you possibly can.
Apologies to interrupt you, because I just want to pick up on something.
Sure.
Delivery plans only work if there's accountability, and that accountability essentially is as quick as possible, obviously without being overly onerous. So I just want to pick up, okay, on these delivery plans, how does the accountability work, and how quick is the monitoring and the ability to react to things if they don't go as planned?
So all of the savings proposals have come from the directorates themselves, so there hasn't been a central cross-cutting arbitrary saving that is imposed that people then may debate and say, well, my area's different and you need to take these things into consideration, that's why you won't get that saving from here. So all of the proposals have come forward, they're supported and owned by the corporate directors and their teams. So each of those delivery plans, each one of those savings has an owner. It has an SRO. It has a project name, or someone who will be responsible for implementation of those. So the ownership is very definitely there in terms of names against these proposals. And then, sorry, what was the other part of it?
In just terms, okay, the name's there, so that's good. But how is that person being held to account, and how quickly can issues be spotted and something happens? Because obviously, if somebody has a name and then we look at it 10 months' time and you think it hasn't worked, that's a worst case example. Yeah, then so actually doesn't matter. I
mean, I talk from the high level perspective, but from a corporate perspective, I will want those particular, higher risk items to be discussed on a monthly basis. So somebody within my team, so Martin, for example, to talk with those people within the service area who are responsible for delivering those savings, to understand how they're progressing with that work, to make sure that we centrally are made aware of anything that is heading off course, and then we can have discussions at a more senior level on how those are addressed.
Yeah, and just to add to that, so savings in my area will be reported on at my SMT with my senior officers fortnightly, and we will meet with Martin in finance as well. But additionally, there is monthly reporting on an app that is shared with SMT, so as a group of corporate directors we can challenge each other if those, and we look at the monthly reporting to ensure things are on track. The onus is on me to make sure that they are being delivered, and as Steve says, we've identified the savings in our own directorates, each of the directors, and that is because a good proportion of the work will need to be transformational, and so it's important that operationally we're making those changes to be able to deliver the savings, and it's both modernising practice, making efficiencies, and addressing the deficits basically that we have in the service area.
Yeah, Martin.
But should I add something from my point of view as a person who will have to, well, it won't be me, it will be my successor next year. We'll have to work closely with Sandra and her team. Each of these savings will have not only a name, it will have what will be done, when it will start, how it will be phased, when it would be delivered by, and how it would be measured. And all of those things will be essential to demonstrating that it is being delivered or identifying at the earliest opportunity if something is slipping. And I think that's the level of detail that's essential to delivering savings, and it's something that we know that Hillingdon's fallen down on in the past.
That's why I was asking those questions, so thank you for that. Councillor Chandel.
Thank you, Chair. Thank you, Steve and Sandra. I don't envy you in your role of putting this budget together, and I can never get my head around this, because we've talked about it before, that we're not making any cuts in adult social care, but it seems never ending, because I think once you're in the system it just doesn't seem to stop, does it? And you're constantly providing care, and it baffles me every time what contingency is there, because more and more, like you said, we're finding more and more people with different types of mental health issues. We talked about it before about I'm not going to name any particular conditions, but we talked about it more, and that I can't get my head around that. How do you then plan for new things coming in and an increase in delivering those services to help the communities? I just don't seem to find how that balances. Maybe it's just me being a bit simple, I don't know.
It's tricky, but what we have done, and that's what I was talking about at the beginning, is we've looked back. We're looking at all sorts of influences that could increase or decrease our numbers. So what's the population telling us? At the moment, what we know is in Hillingdon, our over 65 population is growing, and so therefore the likelihood of demand on services is growing. We also know the population of younger people with quite complex mental health needs. Young people with SEND are in our population. So that's the first kind of starting point to the modelling. So what we know, what we're doing with all of those people's, their client groups and their primary support reasons, we start to look at how many people we think we're going to be needing to provide services for. Additionally, we then need to look at what's the average cost of providing support for those individuals. And now, this year, what we're also looking at is, so what is the transformation work that we're doing that changes the way in which we work that will address some of that cost? How are we working with the market? How are we working with the individuals? How are we helping people be more independent? What services are we buying? So we buy a lot of, in Hillingdon, we buy a lot of third sector suppliers that give early intervention services. So how do we get people to access services much, much sooner so that they don't come into our service area? So that counts in all of the modelling of the amount of placements or interventions that we might need for our residents during the next year. I mean, that includes things like Sharon's talked about investing in the cardiovascular scheme that we're about to put on Know Your Numbers, which is if people have well-controlled blood pressure in this borough, they're less likely to have demands of having a heart attack or a stroke or being acutely unwell, which means they're less likely to need adult social care. So all of those things contribute to how we form a model of what the demand will look like, as well as learning from a whole range of, so ADAS, London ADAS, the Association of Directors for Adult Social Services, and how everybody is, what experiences people have to make sure that we fully understand the likely demand on our services in the coming 12, 24, 36 months, and the health conditions and behaviours of those people that we will be supporting over that period of time. And that's how we've put in a contingency that says we expect there to be this amount, but we need to be mindful that in this year we saw a seasonal fluctuation that might happen in, bizarrely, Easter and January. January, I understand, it's winter, it's Christmas. We have very seasonal fluctuations of demand, and most recently, in the last couple of years, we've seen that in August as well. I suspect it's weather, and part of that, and health-related conditions, we're seeing a higher demand at those periods of time. We might also see seasonal fluctuations in terms of term time, people leaving college and schools who have special educational needs and have demand on the services. So those are all the things that feed into how we look at what we're going to need over the next 12 months.
Councillor Punja.
Thank you, Chair. Before I ask a couple of questions, I would like to just make some kind of notices and statements on this. I find it really hard to scrutinise something when I don't see the narrative behind it. And to come in here when we've got like a £16 million growth rebasing put into this, which kind of demonstrates the overspend that we had this year, plus what we've got in the modelling coming up next year, I would have liked to have seen the narrative behind that of how you got to that. You've explained it here today, but for us to scrutinise that, I would have liked to have had that beforehand to kind of appreciate what we're actually scrutinising. Then when it comes down to the savings proposals, I would like to understand where that narrative has come from or where that modelling has come from, so that when you've got £400,000 coming out of a telecare review, we should be able to read that so that we can ask very simple questions back again or scrutinise that better. Here, there's nothing to this is for a £16 million, which is nearly a third of the growth budget, we've got very little narrative telling us what is going on and what you've done. So we've got to trust in what you're saying now in the modelling, which is similar to what we had last year that came into this committee. And I really want to understand more about that modelling per line, really. I want to be able to have an explanation of where those savings come from, what's the impact on the services, what has been left out, so that we can know that this time round we're not going to have to go, as everybody here has said, in month 2, month 3, month 4, with somebody being held accountable. And the question that wasn't answered about was the agility to respond, because it's all very well saying that I'm accountable and we've got this plan, but where is the agility if the plan isn't working? And that is not being addressed. The other part of this I would like to ask about is, again with the modelling numbers, we're talking about £16 million in ASC placements, and a lot of that is inflation, but there's 3.6 in demand. And you talked about different variations, but those variations could have been put in here, and I don't really understand where those variations come from. And therefore, how do we know as a committee of what we're actually asking you in the future and in now according to this budget? Because we have to vote on this budget. I'm just kind of, and also in fees and charges, it's going up by 10%. What fees and charges are going up by 10%? We've got a load of statutory services and a lot of non-statutory services in here. Where is this kind of hitting those marks?
I guess the question is, to what extent we go through some of that detail here this evening.
Yeah, no, I mean, there is the sort of broader point, which is more narrative would have been useful. And there is obviously a confidence and trust point based on previous years in terms of what we might have been told of the committee and what's actually happened. Now, from my own perspective, partly because I sit on an audit committee, and so I've been looking much more in depth at this across Hillingdon, I am broadly satisfied with what's been put in place, but that's because I sit on an audit committee, so I've had the sort of privilege of seeing how that's worked across the organisation. I think we have two choices. Either, obviously, and you can do this, you can try and answer as much detail as you can now, or we could have some more narrative and a more in-depth session for those committee members, including myself, actually, who would like to have that on this. I don't know, is that possible timing-wise?
We need to get the comments ready and in the next week.
Okay. I mean, our comments could reflect the fact that more narrative would have been useful, obviously, because, you know, the answer you gave to me about I mean, Councillor Punja's correct. The agility point wasn't picked up, but I did ask loads of points. So, that happens when you ask lots of questions at the same time. But I think actually, just in general, certainly if we're going to be carrying on monitoring it, if the budget passes when council votes for it, this committee is going to be sort of looking at it and how it works over, the following year. Knowing more details around the modelling and that accountability and how that works would be useful. So, I suppose because of our timeline, obviously have a go at sort of talking about. I mean, is there a couple of specific points, Councillor Punja, you'd like to sort of get more detail on at this stage, and we can reflect sort of the wish that there was more narrative for us to look at when we make our comments, maybe?
I think we would struggle to make any meaningful comments on something that hasn't got the narrative behind the modelling for us. I really do. I would like possibly that this is taken away, that you've got the information because you were telling us most of the information, but that needs to be in writing, not in a kind of a moment here where we can't absorb, digest and then come back with questions. So is it that we get an email with some of these things about the narrative behind how you have come to the savings, what the impact on services are, what your mitigations are and risk assessments are, so that we can trust that kind of the 3.26 total there is right. I want to know about the growth. How have we got to those modelling points? Because you say you've got all of this modelling out, but I just want to see what that breakdown is. I really do, because otherwise it's just saying, well, okay, that's what that is, and then next year we'll come to this point again, and it won't have been met, and we'll be in the same. We're in a very precarious financial position in this council, and health and social care is a statutory duty that we have. This is one of the most important committees in which we need to have that narrative.
So rather than being a question and answer session, obviously it's a turning conversation. But I mean, on one point, I am comfortable that we can make meaningful comments. We can build in the narrative point and knowing more information, especially if there's no time to go into as much detail as we'd like in terms of future monitoring. But I suppose from Councillor Punja's point of view, is there anything in the next, obviously try answering that question and her challenge right now in terms of detail, because obviously it'd be useful for us in terms of making our comments, and obviously Nikki's noting stuff down, so it goes into writing. But is there anything that can be shared over the next few days, do you think?
Sorry, Chairman, is this not in the draft budget as well? Because there's a big section in the draft budget about health and social care which should answer a number of these questions. Am I not wrong that with the draft budget that was released, a lot of this can be answered from that?
There are various elements that are in the main budget report to which we draw reference, which talks about inflation assumptions.
Okay, right. Stop.
So if we
stop, please. People starting to talk over. Really, really important for conversation. What I want to do is just have an answer from Steve and Sandra on this. Thank you, Councillor Davis. That was useful to point to the main budget, and then from that answer we'll go forward. Okay. So if that's okay, rather than us talking over on this issue. So, Steve, Sandra, if you could answer the challenge that's been put to you by Councillor Punja.
Apologies that you haven't had the narrative in the way that to allow you to scrutinise, but we can, as you can see, we absolutely have that information. We can put a narrative together on each of the savings proposals for you without problem. So we can do that for the committee. How would that best be sent in an email?
Definitely. If that's okay. And especially if it's allowed to be public, it can be sent to us in an email, and then it can be attached to these minutes. Is that okay? If that's okay. If so, mindful that it'll be a public document, because obviously it's part of our considerations what you send to us.
Well,
Steve?
Yeah, I would refrain from providing a load of detail on the modelling, because I think that's just too much detail. But I think a high-level commentary on each of the proposals we can do.
Yeah, I think that's fine.
And just in terms of the fees and charges, I think we can probably answer that point as it is at the moment. Fees and charges in terms of statutory social care services are set, so council can choose to or not to charge residents. We charge on the low side at the moment in comparison to our near neighbours and others in London, and it's most social care, well, all of social care needs, people have to be eligible, and there is a framework against which those judgments are made. So I can send you a bit of detail on that if that would be helpful.
Thank you. Councillor Martin.
Thank you. Possibly a less challenging question, very similar to what Councillor Chandel was asking, and we've discussed this before, is this kind of trajectory of the services and the demand going up and up and up since COVID, and I ask you almost every time, when will it ever come down? And it's commendable, the services we offer, it's commendable that the access to them is an obligation, and regardless of the cost and what you've budgeted, those services are being provided. But is there a chance that people fall into a trap, into a system, that once they're in our social service system, is the same emphasis on providing those services and the funding? Is the same emphasis on getting people out of the system or helping them out of the system so that the cost doesn't keep rising so we can get them out? And do you have any numbers that would support how many exit versus how many enter in a month or a yearly basis?
We can certainly get you those numbers because we keep a dashboard of that information. Exiting the service is really important for those people that are able to, and it's our duty to only provide the least restrictive support that is necessary. So if you're a younger person coming into the service, it's our duty to do everything we can to support that person to become as independent as possible. Older people are on a different trajectory, and so they come in with lowish needs and those escalate. Younger people come in with very high needs, and we should be de-escalating. So that's the way in which the ethos of social care should be working. In Hillingdon we've got a very good, and we're very proactive in terms of our early intervention, and we should always be working towards trying to direct people to support themselves, and in any way that they can, utilising those early intervention services, support services in the community, so that they can actually live independent lives and the dependency doesn't keep growing our numbers. But just statistically in Hillingdon Adult Social Care, we have a very stable number of residents. So our starters and our leavers is very stable, which is very positive. It's just that the fluctuations in who that is was quite affected by COVID, and you're right, we have had those discussions, and I would say I personally can see that that has, in the last 12 months, that has settled. So we're starting to see that tail off now. But what we had driven from that period of time was a lot of young people without the appropriate daytime activity, education, support, that have had a long period of time where their needs have increased. And we've also seen a lot of people with a higher level of mental ill health. So we've seen those areas grow, and we suspect that is as a result of the impact of COVID in those groups. But evidentially that's still quite something to kind of play through over the years. But certainly in older people we have a very stable cohort of people. What we do see, because you can see that through the budget, what we do see is the cost and complexity of those individuals. So our eligibility criteria is good, our front door screening is very good, but what we see is people have more services at a higher cost, but the numbers of people remains fairly stable.
Thank you. Councillor Davis.
Thank you. So just to ask that question so I get some clarity, a lot of the information that we could find is in the draft budget. Yeah? So just so we can use that. I understand it's a big document, but it is in there. It can be found. I've just had a little look myself, so it is definitely in there. My question is based on SEND. we've seen that over the years Send has blown up massively. Send Transport, I can see we have made a slight saving. Is there any plans in the future to review the Send Transport, the way it works? My mum worked on that Send Transport for the council for 28 years until she sadly died. So I've got a big soft spot for Send Transport, but I also know there's a number of ways that potentially we could be saving on that further than what we've done already. Is that something that we're looking at down the line? Is there a plan for that? Because I would assume that if we allocate for 30 spaces on Send, and all of a sudden we have an influx of 50 children that come into the borough that have additional needs, we'll have to allocate transport to them. How are we looking at protecting ourselves for potential growth with Send Transport, etc.?
You will have seen over the last 2 years that the growth in Send Transport has dropped significantly. That's been a number of factors. First of all, the really diligent work that's been undertaken by the Send service and Abby Preston's work to manage that really well. And secondly, the development of school places in the borough locally. So we don't have to transport our children out of borough. And that's made a massive difference in the cost to Send Transport. And if your school is local, eligibility is done in miles for Send Transport. So if you have a local place, the chances are that there may be a less eligibility for local children because it's a closer to home school for those children. So that's really made a significant difference, and that will continue as school places locally are developed in Hillingdon for Send children. Additionally, we have a new programme of post-16 transport, and the more provision we have close to home, the better it is for our children and young people, and the cost is improved. So there's lots of work going on in Send Transport. They've made the council significant savings over the last couple of years in managing what has been a massive demand growth, which is now controlling, is back under control and is actually being really well managed through the Send team, and is a really good service actually.
Chairman, may I ask a second question? Yeah. So telecare, I can see there is a big saving in telecare, but from the budget, it sort of seems like we offer over the years we offered a gold service, but that gold service was the same gold service for everyone. So are we now offering a gold service tailored to your needs? So if I don't know, you're a lady with dementia that's in a home, you'd need maybe a bed sensor, a door sensor, etc. But if you was an elderly person at home that may just be having falls, etc. So we're offering the best service for you as a person now, rather than the same 100% service to everyone. Is that my understanding? Is that right? If you understood that.
I'll tell you what I think I understood. So telecare has been around for a very long time and has been an excellent service, and we offer a very good, very, very good service in Hillingdon. And what we need to do is to, it sounds a bit at odds me saying this, but improve our core offer and ensure that not everyone needs a gold service. So some people just need a digital from analogue, because that's happening this year, pendant and a monitoring system, and some people need sensors and check-in systems and all sorts of other digital. Everything comes under the banner of telecare, but actually, which is a lot of sensors that can be all sorts of things, including all sorts of alarms. We need to review that, and we need to ensure that we're offering a proper digital service. So we're in the process of removing everybody's analogue boxes that could plug into landlines, switching them to SIM-based equipment, and doing reviews to ensure that people get the right service for them. Almost all of a very small proportion of the people that use telecare are social care users. Almost all of those are our general needs residents.
Sorry, Chairman, just one final point on telecare. And are we now collecting the the stuff that's not used anymore. If someone stops using the service, are we now collecting that as well?
So each piece of kit, as we're swapping it over, is getting the standard, the stick-on label with the how to return it and what you need to do. All of that has been revamped, is being looked at, and will be part of the whole process to get us to the end of this year where the digital switchover takes place. So it's been a good opportunity to completely refresh the service, actually.
Thank you. Thank you, Chairman.
Thank you, Councillor Davies. Councillor Bells.
Just very quickly, because my question was on telecare as well, and my mum's a user of it, so and it's been a very good service. So I think you've answered what I was going to ask, but as long as as long as the standards don't drop, that's what I'd worry about, because it is a very good service, and a lot of people would miss it. And I know I was visiting someone in hospital over Christmas, and they got mobility problems, and someone came around and was advertising the telecare service to them, and I just hope that the standard is going to be kept.
It's a core offer for our discharge processes. It's a core offer as part of our early intervention and prevention. It's an important service. It's existed for a long time. It needs to evolve into a modern digital service, and the service that your mum's got probably works brilliantly, is brilliant. It's got a responder service. It works excellent. We've got also a lot of younger people using the service now, so to enable their independence. So we just need to tailor it to a more suitable option for people. As a service, we need to take the time to review it and make sure that we're offering the right service to the right people.
Okay, thank you. I think maybe that's something in the future we'll want to look more in detail about how that's being done as well. Okay, so we've come to the end of this item. So under the recommendations, we have recommendation 1, recommendation 2. On recommendation 3, I don't think we're going to be able to agree specific feedback and recommendations in this meeting. So I suggest instead recommendation 3 be that comments drafted by the Democratic Services Officer based on our discussion tonight be agreed by Chair of the Committee in consultation with the Opposition Lead. Are we happy with that? Thank you. Okay, agreed. That's our new recommendation 3. Thank you. Thank you, everybody. So you're all here for the next item, aren't you, I assume? So next item is the budget spending report. So I suppose the key question that comes out of this report is, though there is a favourable movement, obviously, of 0.2 million in terms of the overspend is still there. So a bit more explanation about where the overspend has come from, and any sort of possible movements that are anticipated in the future would be useful.
I'm happy to go, Sandra. Thank you. The overspend is a mixture of things. It's partly the overspend at the end of 24/5 that happened after the budget was set, and you could rightly say should have been picked up when the budget was set. And it's partly the growth that's happened in this financial year. And it's partly, the third element is those two big savings that you'll see in table 3 in the last two red columns that are not going to be delivered in 25/6 and have been slipped forward into future years. So you've got, if off the top of my head, if I can add up 2.8 million, is that right? Savings
slippage is
3.8, sorry Steve, thank you, that slipped, and the rest, which I make 3.4, is a combination of about 1.2 million that came from the previous year and the growth in year. The important point for me, or two important points. One is that the position is now relatively stable. I think, and I've said this before, you've heard me drone on about it, that we've got a good handle on what's happening at last. And the other important point to make is that in terms of the other report, is that this is being addressed properly in terms of rebasing the budget as you go into next year.
I mean, it is steady from the last time we saw it, so that is a positive, definitely.
Yes. And I'm anticipating it will be steady.
Okay.
Give or take what we can't be certain of. The next time you see it.
Okay. Does anybody else have any questions? Yep, Councillor Punja.
The question that I had on this was just the pressure of the 7.2 million that's in there from this year. How is that being kind of put into the growth? Because has it been modelled into the growth, or has it just been kind of left to one side?
Yes, it has been. First of all, if you take out the 3.4 million, the savings slippage, that's been addressed separately. And you can actually see that in the previous item, in the growth tables, table 3, in the line that says 26.7, placement fee renegotiation 1.739 million. That's one of the proposals. And in the line near the bottom, in section 117, funding split with ICB, that one is expected to be partly delivered in 26.7 and partly not until 27.8. So those have been addressed specifically. The rest of it has been subsumed in that row, third row down, ASC placements rebasing for 25.6, and there is an allowance in there for the fact that the growth that you see in the 25.6 spending report has arisen during the year. There's an allowance in there for the full year effect of that, of about 1 million.
And actually, when you add those three up, they add up to 7.2 million.
Yeah.
Okay, thank you. Thank you for that. So, if no other questions, we'll move on to the next item. So, thank you, Steve and Martin. I don't know if you're staying for this final item. You may leave if you're not going to talk to the final item. So, the final item we have is and my papers are all over the place, but it's the performance report, 6-month performance report. So, my main sort of overall comment is the performance report shows that we provide a good quality service, and also we benchmark very well in terms of the price we pay for providing a good quality service. So that's a very, very positive thing. The one area that I sort of highlighted that I would like to see some improvement on is obviously the 58% of service users are satisfied. Really want to try and get that higher, and part of my question about how to get that higher is part of that expectation management as much as anything else, I wonder. I don't know. I'm putting words in your mouth, Sandra. So, in general, I think this tells a very good story about how we're running the service, so congratulations on that. But on that specific statistic, how can we get service users more satisfied with the service that we give?
Sorry. I share your disappointment in that figure, because it actually is slightly at odds with people's quality of life is good. So, which is a very key indicator to me in terms of people are saying that they have a good quality of life. So it is one of those that we need to look at and understand why that reporting comes in that way. And I also think that it's really important that we do some of our own engagement with our residents. This is the client-led data that comes through the national data collection, and we get it, and it's always a year out of date. So this is last year's, and not last year's, year before, so 24-25. And the reason I've added that into the front of the report is the performance report basically is way too out of date at 23-24, and we know that we've made significant changes since that period of time. So we're starting to see some good data come in, particularly one of the areas that we have had some questions about, which is the number of residential and nursing placements we make, which we've been a complete outlier on. Even though I know that we don't overplace, our reporting has shown, and statistically we have discovered that we report both short and long term, and everyone else just reports their long term placements. So we've corrected that, and that's now demonstrating a really good equal to national, so alongside England and better than London. So those are the sorts of things that the data is really helping us with at the moment. Another statistic from the ASCOF, which ASCOF and SALT are two data collection sources that have changed recently, so the indicators have changed. So some of it is a bit skewed, but one of them is around reopenment. So we have a very high performing reopenment service, and our outcomes are very, very good, usually in the 90%. But one of the indicators that they've reported on this time is that older people, 65 plus, reopenment outcomes is lower than, which doesn't actually look right in terms of the rest of our data. So we need to check and understand why that's reporting in that way, because it doesn't bear out in our known activity. You would expect to see it lower because a number of our over 65 residents may well be going straight from hospital into a short-term care home placement for their step down, as opposed to into reopenment at home. But so those are the indicators that we want to look at and monitor. But it's really positive that we're getting some really good feedback from our ESCOS data, and the fact that we've got live dashboards now to enable us to compare those and have a much more up-to-date position means we can make the changes in the service quicker.
Thank you. Councillor Davis.
Thank you. This was a really good read. I found this really helpful, especially the Power BI bit at the end. I thought that was really good. It says that Hillingdon has the full lowest net expenditure in London per 100,000 residents. How does that fare against other boroughs? So when I look at the chart on, I don't know what page this is, on page 45 it is here, the executive summary. We're down the bottom for expenditure versus somewhere like Camden. What are we talking? Are we talking like millions, or is that because of the number of service users? How has that worked out?
So effectively, it's cost per head per 100,000 of population, and how much we're spending as an adult social care department per head population. So that's across all primary support groups. However, the data that is shared with us for both London and nationally, each December breaks it down into primary support group now, so we can see where we're an outlier. I know that our expenditure on adults with a learning disability in care is high in comparison to other boroughs, so that will drive my commissioning arrangements now for the next year. Our expenditure for care home placements is stable, it's below average, so we can start to see the cost on those things, but it's driven per 100,000
and is it
population.
Sorry, Chairman, is it per, so it's worked out per user really, so depending on the user's needs as such, yeah? Thank you.
As an overall.
Yeah. Also, if I may, Chairman, sorry, the CQC that we've achieved good in the CQC report at 73%. How does that work? Do they come in yearly? Do they come in every 5 years? A bit of information on that would be great.
Sure.
Because that's quite a good achievement.
Thank you, and that was in July 2024. So that inspection was the first on the new framework by CQC of local authorities. They hadn't inspected local authorities, I think it was 12 years. Prior to that they used to, but they hadn't. So this is a new framework. They have almost, but not quite, finished the whole of the country of all local authority inspections now. And we've retained our position as a really good outcome for the department. There are a couple of outstanding, so Camden being one of those, and I think it might be Redbridge. There's another one in London. But actually, there's a lot for us to learn from some of the work that they're doing. So we were, and we work as a group of directors to understand who has done really well. A lot of our near neighbours also had requires improvement scores, so we will help those improve. As they complete all of the local authority inspections, the next inspection that we're expecting, which my best guess will be maybe the end of this year, beginning of next, is they're moving towards a framework very similar to children's, which will mean they won't do a full inspection of us, they'll do a targeted.
Okay.
So we're likely to have something, a focus of perhaps maybe scrutiny and which was one of the areas for us for improvement and policy development, etc. So they'll focus on something that they feel that we had a weaker score on last time, I believe. So it'll be thematic, and it won't change our overall rating. It will just be a letter form, and then I think we'll have probably an on-site inspection within the next 3 years.
Okay, thank you. Thank you, Chairman.
It's a good read, and the executive summary is a good read. So if you want to find out what's happening and how we run our social care service, I'd recommend it to anybody to read. Councillor Martin.
Thank you. Just on the same point, it says Hillingdon has the 4th lowest net expenditure in London per 100,000 residents, and it mentions Heathrow Airport's presence in the borough creates a unique operational and financial challenge. How does that lead into the lowest net expenditure if it has additional challenges? Because usually everything we hear about having an airport in our borough leads to higher costs. How does that impact lower costs in this area, and what are those challenges?
So we talk a lot about the low cost of our services, and I think that's around the way in which we manage our market and our suppliers, and we work collaboratively with them and negotiate the best possible rates, etc. We are an outer London borough, so that benefits us in terms of being able to do that, as opposed to being an inner London borough where expenses are more costly. Having Heathrow in the borough for adults is less impactful than it is actually in children's social care. So the demand on adults coming through Heathrow for adults are relatively lower numbers that may have, some of the areas that we may pick up clients from are people being repatriated from living abroad for very, very long periods of time with no local authority to return them to, with social care needs. So often people will come back and go straight to Hillingdon Hospital, and we'll pick up the discharge. Often people have mental ill health, and we will pick up a Mental Health Act assessment at that point in time, and that attributes that person's needs to the local authority for the longer term. So that is Section 117 aftercare responsibility, which is a duty of the Care Act where that person is assessed. So that's how it's impactful for the airport. Now, my balanced and half full head will say actually it's also opportunities for a lot of our young people to gain employment, and the airport is very supportive of some of our activities for our residents as well. So economically, it's one of those that is important for social care users at the same time, as well as causing a bit of an impact. If you were speaking to Julie Kelly, she would give you a much more significant financial impact due to the children and families coming in.
Councillor Punja.
Thank you. just would. So, where should I start? I want to start with saying that I don't know how you would think about this, but I think that we've, like, in this whole year when we're doing the kind of like what services we offer and the progress we have, I feel that that part of an assessment in the report is missing, of like how we've learnt, the things that we've learnt, things that we haven't learnt, what works, what doesn't work. Because I believe that in your modelling that these are the things that you've looked at to look at your savings and look at your growth plans. And I think that there would be significant things in there that are good news stories or learning curves that show like the improvement of governance and the improvement of things that I feel could be in that 6-month performance review report, just as an outset. What I would like to know is that we talk about a low cost or low spend, let's call it that. I just want to know how the overspend gets factored into that kind of a comment, because where does that kind, is it factored in, or is it just left to one side because it's on 2 different budget lines in terms of that? And then just on top of that, this kind of thought around adult obesity in Hayes and Useley with deprivation and the likelihoods of the high streets being kind of almost takeout shops and fast food, which kind of leads to that obesity and national trend. And I just want to kind of ask about what we are doing as a education authority, in an educational placement, or what it is that we've got in place in those kind of services, because being above the London averages is something that we would want to address, I would assume. So I'll leave it there for a minute.
So, certainly as Martin was talking earlier, we have factored into this year's budget some of those pressures and some of the areas. There was a lag from the end of last year into 25-26 of budget, which has caused a pressure, and the intention, and of course that everybody is always working with the right intentions to make sure that doesn't happen again. I think this year we've worked significantly more detailed to ensure that we have looked at everything that we can to, first of all, we've taken the decision to put that into the growth so we know that that is covered. So the starting point of this year's budget is the right one. The pressure that's on that budget in terms of the reporting through ADAS, so the finance team will report how this gets played out into the national reporting on the cost per head, includes what it's actually cost us. So this is what it's actually costing to run the services. So if there is a pressure, so if it was currently £10 million overspent, that 10 million also gets reported in. And in terms of the public health points, which is something that actually, although Sharon's only just come in, we've been looking at how advertising, licensing, etc. really impacts on the local population, and what we can do to make the changes to high streets in line with business improvement teams, etc. And the advertising of healthier options. So we're not asking fast food providers to stop advertising, because they're not going to do that. But we can ask them to put in an advert a healthier choice, and we can ask for the council to consider that as an option for us to state that that's what we want to happen. So I think that might be something that we can include going forward in the public health information that comes back to committee, because there's a lot to do on our both adults and children's weight management, and we want to talk about healthy lifestyles. We don't want to talk about weight reduction in children. We want to talk about children being fitter and healthier and giving them the chance to be that by the environment they're living in.
There was just only one part of what I said earlier that just wasn't addressed, and it's okay. It was the kind of progress, because this is a 6-month monitoring report and we compare ourselves to other boroughs, but I'm just looking at kind of like, we've been doing all of this work and it feels like we're not looking at, in that performance report, I would like to see this is what we've done, this is what we've done differently, this is what we've learned, this is what we haven't learned. Just, your thoughts on that.
So, of course we want to celebrate our successes, absolutely, and completely agree with you. One of the things that I've been speaking with the performance team about is that we start the year with this report, but it's not a follow-through in at the moment, for me, it is kind of changing all the time. So I want us to start this financial year coming now and to start with a set of indicators that you will follow as a directorate through the year. So adult social care and health, and we will follow those through the year and we'll report on those with you about how what the performance is, what we've done to achieve, and then any narrative at the bottom that actually is about anything else that we've done that you might be interested in. But rather than having an unwieldy amount of things that at the start of the year mean one thing but at the end of the year mean something else, we will focus. If we've got something that we've completed and retired, then we can add something in. But over that 12-month period, I'm sure that you and Cabinet will want to see progress on some set indicators. So that's my intention, and we've worked on that this morning in my SMT.
Okay, sorry. Just closing the item now, but me and Nikki were just talking about the recommendations. Because recommendation 2, obviously it's impossible for comments from this committee to be presented to full council in January, because that's Thursday, I think, if my diary's correct. So instead of that, the committee's minutes will obviously be a reflection of our comment. I don't know how that's incorporated into what's needed for council or not, or if that even matters. But
Chair, it won't be able to be incorporated into the report to council. However, it will be for the record.
Okay, fine. Okay, everybody happy with that? Yeah, fantastic. Okay, well, thank you, Sandra, and thank you, Martin, so much. And thank you, Sharon, for staying with us, because that was actually public health relevant, so that was good. Okay, so we move on to item 9, which is the Cabinet Forward Plan. Does anybody have any comments on that? No? We're all happy to move on. Fantastic. The work programme, I'm happy with it as it stands. Yep, agreed. Fantastic. Okay, well, that's the end of the meeting. Thank you, everybody.
Okay, if you can all remain silent.